Thank you for this kind and friendly introduction. I want to say hi, merhaba from Izmir. This is the city I am located. I am very happy and pleased to be among you at this congress. I want to say Efkaristopoli to Dr. Iraklis Tetopoulos and the whole organizing committee and all my friends and colleagues who are involved in this congress for inviting me. It's really a pleasure. My topic is interventional bronchoscopy in tuberculosis, but I want to touch a little bit to the diagnostic yield of bronchoscopy in TB. Overall, the diagnostic yield of bronchoscopy in TB is about 77%, but it may vary between 11 to 96%. We can have exclusive diagnosis by bronchoscopy, immediate diagnosis, which is important in TB diagnosis, and also we can get culture positivity in 44 to 95% of the cases. The important point in using diagnostic methods in bronchoscopy for TB is uh, to know which diagnostic method to use in which form of TB. If we do not pay attention to this, our diagnostic yields will not be high. I just want to give a few examples, like in miliary tuberculosis, if we do not use transbronchial biopsy and combine it maybe with other methods like bronchoalveolar lavage, our yield will be low. In bronchogenic spread, bronchoalveolar lavage should be diagnosed with other methods, but it's necessary to use bronchoalveolar lavage. Endobronchial TB, you have to use endobronchial biopsy, and other examples like lymphadenitis TB, we should use conventional transbronchial needle aspiration or evas tbna. So know the method to use in which form of TB. Let's come to interventional diagnostic bronchoscopy. We can use evas tbna in diagnosing tuberculosis by using radial probe or convex probe evas. However, the literature in this area is increasing but still relatively limited. We can use EBUS-guided tBNA in tuberculous lymphadenitis, but also in pulmonary TB, which is a conglomeration or a tuberculoma, a nodule, or a mass that is adjacent to the airway. The sensitivity is fairly high, about 65 to 94%. Negative predictive value can be low as 11%. Accuracy is again high, 85 to 90%. Another important point in diagnosing with EPAS TBNA is combining pathologic diagnostic specimens with microbiological specimens. If we combine these two, our yield increases. We should combine cytological smears and cell blocks when sending the specimens to pathology. Then the diagnostic yield for pathological diagnosis increases 80 to 86%. Regarding microbiological diagnosis, the overall yield of EBUS tBNA is 53%. Smears do not give very high yield. Cultures may be positive as high as 50%. TB PCR tests are also important. They can give the diagnostic yield in half of the cases. And also, we can determine drug resistant TB by using EBUS tBNA, but sending the specimens to microbiology lab. So, whenever you are suspecting TB, please send the specimens to microbiology laboratory too. What about EBUS tBNA compared with conventional tBNA? When they are compared, their diagnostic yields are similar, not different. Again, combine microbiological specimens with cytological specimens, and in this picture you see the acid-fast bacilli in the smear, and this is a cytological specimen showing a small granuloma of TB. When using EBUS dbna, you don't have to go and do in the first place EBUS dbna. You have flexible bronchoscopy and or you have rigid bronchoscopy. You can use conventional transbronchial needle aspiration to diagnose tuberculous lymphadenitis. If you cannot get the diagnosis, if the result is negative, then you can go and do EBUS dbna, and in this way you can increase the diagnostic yield from 18% to 80%. When we come to therapeutic interventional bronchoscopy in TB, we do these procedures for the complications of tuberculosis. What are they? Tracheobronchial stenosis, bronchopleural fistula, bronchoesophageal fistula, and hemoptysis. For airway stenosis, we can use different methods such as mechanical dilatation, balloon dilatation, hot treatments, cryotherapy, and stenting. We can use radial probe EBUS for following up the airway wall, the cartilage destruction due to the stenosis, the TB destruction, and also we can use it for following up the patient after the interventional procedures. What is the efficacy of interventional procedures in airway stenosis? Dilatation is efficacious in about 30 to 40% of the cases. Unfortunately, after the procedure, stenosis can recur and we have to repeat the procedures. However, if we combine, say, dilatation with hot treatment or cold treatment, and then, if necessary, stent the patient for at least 1 year, the recurrence can be less and the combined efficacy can increase to 50%. Bronchopleural fistula, we have to know whether it's visualized fistula or not. If it's a visualized fistula during the bronchoscopy, we can use fibrin glue, hemoclipping, gelatinous sponge, or cyanoacrylate that can close that orifice of fistula. But if we cannot see the fistula during bronchoscopy, we have to use something to block the airway that is leading to the fistula area. So we can use valves, spigots, stents, coils, or in some cases, atrial septostomy catheters are used. The efficacy of blocking with valves and spigots is about 70%. For bronchoesophageal fistula, we can also use the similar material, fibrin glue, hemoclipping, gelatinous sponge, or cyanoacrylate. For hemoptysis, I will mention about it more in detail later, but in general, we can use iced saline, adrenaline, electrocautery, argon plasma coagulation, laser, Fogarty balloon catheter, or double lumen tubes. I want to mention a little bit about endobronchial tuberculosis. Why? Because in tuberculosis, endobronchial TB form is the one that causes stenosis most of the time, and these patients need more interventional procedures. That's why I am emphasizing it. In endobronchial tuberculosis, there is always a potential for airway stenosis, so we should be kind of alert and should be ready to diagnose it early and do the early management of it. Here, there is a pinhole stenosis, subglottic stenosis, and interventional procedures are used, and the result is wider patent lumen. What causes stenosis, airway stenosis? The studies have shown that immune status of the patient, particular patient, may play a role in that, and also the TGF beta and interferon gamma levels increased in bronchial washings and bronchoalveolar lavage may have a role in the stenosis in that particular patient. And at the same time, the serum levels of TGF beta are lowered, and metalloproteinase activity is also upregulated in these stenotic patients. There are different forms of endobronchial tuberculosis. I'll just go over them fast. Non-specific bronchitis, as in this picture, is mild mucosal hyperemia and swelling there is good prognosis. There are not many cases having stenosis. The hyperemia swelling form has bad prognosis. The stenosis can occur in up to 64% of the cases. Granular form with good prognosis, the view during bronchoscopy is with diffuse white spots. Stenosis can occur in less than 20% of the cases. Active caseating form is one of the bad forms. The prognosis is bad, and for sure, in this form, granulation tissue occurs, and then this leads to stenosis. Ulcerative form is with good prognosis, no luminal narrowing, just mucosal ulceration as seen here. Tumorous form is with unpredictable prognosis. We have tuberculomas, mass-like nodules, masses in the airway, and this can lead to stenosis or not. It's kind of unpredictable. Fibrostenotic form is the worst form with very bad prognosis because initially the patient can present with the stenotic airway as seen here, and it's occurring in 90% of the cases. So this is the form most frequently requiring interventional procedures. All of these different forms of endobronchial tuberculosis can lead to each other, can progress to each other. But what is important is, or the critical point is, the development of granulation tissue. If granulation tissue occurs, then fibrostenotic airway is kind of inescapable. It's shown that the length of involved airway and decrease in FEV1 are the risk factors for persistent stenosis. When we are assessing the degree of bronchial stenosis as mild, moderate, or severe, as shown here, we have to also consider the functional activity of the patient, whether the patient is living a very active lifestyle or a very sedentary patient not moving much, because this will affect the decision for the interventional procedures. Let's give an example. This patient with moderate stenosis, the lumen is about obstructed about 34% to 66%. If this patient is very sedentary, he may not be symptomatic and have no dyspnea. But this patient with very mild stenosis, up to 33% of the lumen obstructed or stenotic, and this occurs in most of the cases, if this patient is a sports person or living very active life, this mild stenotic patient may be more symptomatic regarding dyspnea than this moderate stenotic patient. So pay attention to the functional activity of the patient plus the bronchial stenosis, degree of bronchial stenosis. Of course, in the last form, where the stenotic bronchus, the lumen is stenotic from 67 to 100%, almost pinpoint narrowing. Of course, this patient will be dyspneic even with little effort. In these cases, it's kind of emergency to do the interventional procedures. The treatment goals are the treatment of tuberculosis, the anti-TB treatment, early diagnosis and treatment of potential stenosis, treatment of established stenosis, maintenance of airway patency, and of course, following up the patient as we have to do in all parts of medicine. What do we do in the workup for management of airway stenosis? The main instruments are CT, white light bronchoscopy, and radial probe evas. Here, as we see, we can visualize the inner appearance of the stenosis, but we can see the length, width, location, and the neighboring tissues on CT better. And that is not enough. We have to see the airway wall, whether the cartilage is destructed. Here, the cartilage is broken or destructed. That is not a good thing, prognosis. But here, the cartilage is intact. So we have to all assess these by three methods. And then the assessment should be quantitative and qualitative regarding morphology, location, extent, severity, complexity, and dynamics of the stenosis. We can use from time to time virtual bronchoscopy to assess lumen size and distal lesions, to follow up the degree of stenosis, also to follow up some patients that are not fit for bronchoscopy. From time to time, if required, we can inject steroids, dexamethasone, methylprednisolone, triamcinolone, at the base of the lesion by using our conventional transbronchial aspiration needle as seen in the picture. And of course, we have to do proper anti-TB treatment. These are just palliative procedures if the patient is symptomatic due to this endobronchial involvement. What else do we do? Cryotherapy can be used for granular lesions during the diagnosis or follow-up, or it can be used prior to balloon dilatation to get rid of the nodular lesions that are obstructing the lumen. It can be repeated every 2 weeks till there is no lesion seen. Argon plasma coagulation is another good method for tumorous or nodular lesions in the airway. It can be applied till there is no stenosis, but we have to apply coagulation mode, not very high power. 30 to 40 watts is enough. Electrocautery can be used to cut the web-like stenosis, which is the involvement of the mucosa only. If we have 3 cuts in the lumen, in the web-like stenosis area, then dilate the bronchus, the result will be much better. We can use laser also for the same purpose, but laser has an immediate effect, immediate relief, but also very fast effect and deep penetration. The one who performs the laser has to be very careful regarding this effect. So we have to be careful about the risks borne because of this immediate effect. Intermittent low pulse is enough, and 40-watt power is also enough. When we are doing mechanical dilatation, we should be very harsh and fast acting. First, use balloon dilatation gently before any other, like before doing the rigid bronchoscopic dilatation. If the result is good, stop. But if the result is not enough, the lumen is not opened enough, rigid bronchoscope can be used in a cork-like motion to dilate, but it should be started with the smallest lumen, and then we can proceed with the larger diameters of the rigid bronchoscope. Because if we do very harsh dilatation, the stenosis can return back faster. In balloon dilatation, as shown here, we can use for French Fogarty balloon catheter. We can insufflate 2 or 3 times, about 5 to 180 seconds. If there is recurrence, it can be repeated. The procedure can be repeated. Stent insertion, it's very important to not use metallic stents, expandable metallic stents. Why? Although they may be covered in time, because these patients have these stents indwelling at least 1 year, 1.5 years, sometimes up to 2 years. In time, there is metal fatigue, and because of the metal fatigue, the metal parts break and go into the mucosa. The result is a disaster. Even surgery cannot solve it, and removal is difficult. So it's better and recommended to use silicone stents. First, dilate by using balloon or rigid bronchoscope, and if the lumen is not patent enough, use silicone stent and keep the stent there for 12 months at least. Of course, silicone stent has complications, and the most important complication is granulation tissue in most of the cases. For this, because they also occlude the bronchial lumen or tracheal lumen, Topical mitomycin C can be used. It can be we can have gauze and put mitomycin C on it and put it through the bronchoscope. Of course, gauze is put later. First, push the forceps, hold the gauze, soak it with mitomycin C, and then press mitomycin C absorbed gauze onto the granulation tissue for 2 minutes. This will be helpful. Of course, it may be repeated several times. When we want to take the stent out, when should it be? How should it be? It should be later than 1 year after stenting. Maybe it may require 1.5 years to take the stent out. It depends on the particular patient. But if we check by CT, there should be an air pocket of 1 to 2 centimeters or more around the stent, between the stent of the airway and the airway, so that this means the airway can is stable and stays like that, and this has been shown to be an indication for higher success after the removal of the stent. If the stent stays more than 2 years or has to stay more than 2 years in that patient, that may be an indication for failure, which indicates again tracheobronchomalacia or bronchomalacia, yeah, where it is. I mean, if there is malacia in the airway, it means that cartilage is ill, cartilage is not working, and there can be collapse if we take the stent out. In these patients, the situation is not very good. Maybe stenting will be required longer, or other treatments may be required, like surgery and others. Closure of a TB bronchoesophageal fistula is shown here. As you see, esophagus is here and the distal part of left main bronchus, and there is a fistula very difficultly seen. And during bronchoscopy, you see the orifice of the fistula, and they use cyanoacrylate to close it. After a while, several days later, they see it's closed. What about hemoptysis? That is a complication of TB. Bronchiectasis, fungus ball, broncholithiasis, destroyed lung, vascular erosion by necrosis, or the increased fibrotic area uh, due to tuberculosis as a sequela. Naturally, the body increases the bronchial artery collaterals in that area. And bronchial arteries are connected to aorta system. So if they bleed, they really bleed. So these are the reasons. What do we do? First of all, we should take a thoracic CT and see the details about hemoptysis, what is the cause, location, etc., and then do bronchoscopy. Again, main principles, if there is life-threatening bleeding, use rigid bronchoscopy. Flexible bronchoscopy can be dangerous in that case. Rigid bronchoscopy gives a very secure airway. Also, it is good for aspirating blood and secretions, much better. Of course, ice, saline, adrenaline, thrombin, fibrinogen components can be used as helping aids. Electrocautery, laser, argon plasma coagulation can be used only if bleeding site is visible during bronchoscopy. Fogarty balloon catheter can be used to press the visible area, to tamponate the visible area, but also it can be used to block the airway where the hemoptysis is coming from. Intubation with double lumen tube can be used, so that one lumen is giving air ventilation to the non-bleeding site. The other lumen is used to aspirate the blood or to do the interventional procedures for the hemoptysis. Bronchial artery embolization can be used in cases where the hemoptysis recurs or where interventional procedures are not helping. Selective surgical treatment can be used in some patients, such as resections, such as lobectomy. This is a very busy algorithm. I won't go over it completely, but I will try to touch the interventional part of it. Whenever there is massive hemoptysis, ask, is there acute respiratory failure? If there is acute respiratory failure, admit the patient to ICU, use rigid intubation, rigid bronchoscopy, clear the airway, tamponate the bleeding, and isolate the contralateral normal lung. Put the patient on the lateral decubitus position on the bleeding side so that bleeding does not go to the normal side. There can be volume resuscitation if required. If there is a need, correct the coagulopathy and always have bedside chest x-ray. After this, we have to ask, where is the bleeding coming from, the localization. If we can see that, then we have to see whether it's endoluminal or not. If it's endoluminal lesion that is bleeding, that's the area we can do interventional procedures such as laser, argoplasma coagulation, electrocautery, and also we can use epinephrine, ADH analogs, and the bronchial stent tamponade. If this is successful, good. But if it's not successful, we can have emergency bronchial artery embolization. And if the patient is fit, surgery can be done. If the lesion during bronchoscopy is not endoluminal, then we can use the epinephrine and ADH analogs. We can use balloon tamponade to block the airway that is where the bleeding is coming from, so that it doesn't go to the whole lung or to the other lung. We can use, instead of balloon, we can use spigots. We can use biocompatible glue, stents, some stents to block the area, the airway. And if this is successful, this can be a bridge to bronchial arterial embolization or surgery. And I want to finish my talk with the words of Professor Atul Mehta, who is a good friend but also a very successful interventional pulmonologist, not only because he's doing interventional procedures, but the way he behaves in interventional pulmonary area. His comments, the whole slide is from him. Because it could be done, that doesn't mean it should be done. Good interventional pulmonologist knows when not to perform a procedure. One has to be larger than his or her abilities. No procedure should be performed just to maintain skills. Reducing healthcare costs is a civic responsibility. We all will be a patient one day. Primum non nocere, first do no harm. This is by Auguste Francois Chomel. And thank you for your attention.
Thank you for this wonderful talk. Can I ask a couple of questions?
Yes.
So, when you have a stenosis, when do you choose to put in a stent? Is it in the beginning of treatment, or during the course of treatment, or afterwards, or doesn't it play any role at all?
Yes, we have to do anti-TB treatment. The important point is how symptomatic is the patient? Is the patient dyspneic, severely dyspneic? Of course, we want to say have some time that anti-TB treatment is given, say 1 month. In some patients, we may not wait because if there is a pinpoint stenosis, you cannot say this patient has TB, active TB. I cannot do as we do in COVID patients, the same. But if the patient can wait, if the patient can get oxygen, can wait for a while, at least 15 days or 1 month with anti-TB treatment is much better because we have to protect ourselves. Also, the patient gets more stable, but we cannot say this is the time. It depends on the particular patient. We have to individualize the treatment, the interventional management.
But you believe that if you can wait for a month, then it would be best. If you can
Yes,
wait. Then,
Yeah.
yeah, okay. And another question is,
On the, I would say the inner appearance, the status of the patient, the, I would say, systemic diseases of the patient. I mean, not every patient is only TB. They may have diabetes, cardiac disease. So if there is a patient scenario, it's much better to talk on that patient. If the, how do you say, scenario is emergency, you don't wait. You just do it.
and another thing for the diagnosis of TB, when do you choose to perform a bronchoscopy? When the patient doesn't have any sputum at all? Or would you do a gastric fluid first and then do bronchoscopy to obtain a sample? Because in our department, we choose bronchoscopy. We have the support of the bronchoscopy team, and bronchoscopy is our number one option if the patient doesn't have any sputum. What's the situation in your center?
In my hospital, we get first, we ask the patient, is he bringing up sputum? And they sometimes show you the sputum, it's just saliva. And then we don't wait, we just immediately go because some of them are dry, they don't bring up sputum. But if the patient is bringing up good sputum, we at least look at once. If it's positive, okay. But if it's not positive, we don't wait for the second, third induced sputum. We just go directly to bronchoscopy, protect ourselves, and this has been going on, and we are not infected, not so many infections. We do it as fast as possible because when you wait long, the patient is infecting so many people.
Thank you so much.
Thank you very much,
I
Professor,
thank you.
and for my part for your excellent talk and showing us some such a. Thank you very much for your excellent talk from my part and showing us these great pictures. Hope to have you to our next Congress physically.
Yeah, I am also enthusiastically waiting for the next congress face to face. These are good, but these are a little bit artificial, away from each other. We are Mediterranean people. We want to see each other, talk with each other. So I hope next year I will be there.
Thank you very much. Have a good day.
Aristopoli, and pronouncing right.
Και κλείνουμε το